Welcome to Stroke Buddies Tuesday Stroke Survivor Support Group meeting. We have these meetings every Tuesdays, and we'd love it if you would join us. We realize that a lot of people can't fit it into their live schedule, so we put them up on YouTube where you can watch them at your convenience. And this week we have Dr. Carolyn Falconer with us. She's a speech therapist, pathologist, and expert in aphasia. And so I would like her to tell us a little bit about how she got involved, interested first, and then involved in speech therapy, and then go through a little bit about what aphasia is and some of the forms it takes. And then she's going to give us a little presentation on 10 things, 10 ways that you can communicate better. So I will turn it over to Carolyn.
That's not bad.
Thank you, Ralph. Hi, everyone. I'm Carolyn, Dr. Falconer, and I am a speech pathologist, and I teach people becoming speech pathologists in master's programs, how to work with people with aphasia and related disorders. So I guess getting to the question of how I got into speech pathology in the first place is I was sort of born into it, I think, because my younger sister was born with a cleft lip and palate. And so her older sister, I was always the one who could translate for her. I always understood her. And when people didn't, I would explain what she had said. And then when she got into speech therapy, as she had surgeries to repair things, I was always the one who practiced with her and did her homework with her. So I kind of thought I was interested in something like that. But then, as many people do in high school, I kind of thought, well, you know, I should probably be a doctor, a regular medical doctor. And so I went to school thinking that's what I wanted to do. Yeah, and then physics, calculus, and chemistry weren't my best friends, it turned out. So I wound up majoring in linguistics, which is the study of language in many different forms, and then went for my master's in speech language pathology, thinking I wanted to specialize in cleft palate. But then when I got exposed to everything, because we cover the lifespan, so speech pathologists work with everybody from NICU babies who have trouble latching and feeding, all the way up to end of life care, and probably again mostly with swallowing at that point too. But we do all speech, language, swallowing, and cognition work. So we're trained in a lot of things, and we have to become fairly competent in many things. I mean, you can't be an expert in everything, but we're exposed to quite a lot. And I started getting very interested in people with acquired language disorders who had had some sort of stroke or brain injury, and helping them recover language, which ultimately led me back to school for my PhD at NYU. And my dissertation was on the use of transcranial direct current stimulation in aphasia therapy, as well as pairing robotic right hemiplegia therapy. So like for people who had left strokes with aphasia and right arm weakness, I was working with OTs who were using robots and transcranial direct current stimulation to see if those interventions also aided language without therapy. So whether those stimulations and enhancements were assistive in people returning language competence without speech therapy even. So just like enhancing neuroplasticity in general for language recovery. And so I continue to this day to work in the field. I work privately with patients, and I teach at the master's level, as I said. So that's pretty much my professional journey. And then as far as aphasia goes, so aphasia is a language disorder, and speech language pathologists generally distinguish between speech and language, with speech being the product what you actually produce. And so it's more about motor, speech control, and voice, and how all of that actually comes out and is articulated. So that's more of the physical production of what we call speech. Whereas language is sort of more the symbolic use of words as symbols to represent our thoughts into language. And we encode that in the brain, and then it's fed to other areas of the brain to then be produced as speech. And furthermore, then, it requires muscular control for the speech as well. So there's several different disorders within that sequence that I just described. So when you can't think of the language, can't think of the words, can't put the words together in grammatical sentences, that's expressive aphasia. And so that would be types like Broca's aphasia is the most common one. And it's usually caused by a more anterior lesion on the left side. So something more towards the front of the brain. And that neighbors areas of motor control for the mouth and other articulators, and as well as the arm, which is why my dissertation, as I was saying, sometimes the right hand and left language can both be affected by the same injury. And so, so after thinking of what you want to say and putting it together in sentences as the expressive part of language, and a deficit in that area is an expressive aphasia, like a Broca's aphasia. And there's other types that are similar with slight distinctions. But as you said, I'll just go broad strokes. Oh, that was a bad joke, I guess. That wasn't a joke, but it just came out bad. Anyway, so then the other part of language is more if you have a more posterior stroke. And again, both areas can be affected with a larger stroke, but a more posterior stroke will likely affect Wernicke's area and cause a receptive aphasia or an aphasia where you have trouble understanding. And so people with a Wernicke's aphasia have more trouble understanding language. And that's called a receptive aphasia. And again, there's other subtypes that are similar, but those are some of the main two are receptive and expressive, with Broca's and Wernicke's being the two biggest. And so the aspects of expressing yourself with language or understanding language are the aphasias. And then if you have problems, then once you've thought of what you want to say and understand what's incoming and produce the response, then what happens is that signal is sent to motor control areas of the brain, and it's sent down for planning and programming. And any interruption in that signal is apraxia of speech, which is a very related disorder. And many people with an expressive aphasia may also have apraxia of speech, because the two areas in the brain for language production and for sending it forward for programming and control are right next to each other in the brain. So the same damaged area can sometimes affect both. And so you can very often have a Broca's aphasia and trouble thinking of words and formulating complete sentences, as well as programming problems, which is the apraxia of speech. And that sort of symptoms of apraxia of speech would be things like mixing up sequences of sounds, having more difficulty with longer syllabic words, like multisyllabic words, as opposed to shorter words, which would be easier to program. Connected speech, so longer sentences being harder to produce than short sentences or single words. And inconsistent errors. So sometimes it comes out great, sometimes it doesn't, and each production might come out differently wrong. Whereas then the next disorder down would be dysarthria. And dysarthria is when something at the motor level, at the end of the neurons or the muscles, are not working. So whether you have some weakness or spasticity, because either the signals from lower motor neurons aren't getting to the muscles, or the muscles themselves aren't working. People with that disorder will have consistent errors. They'll always have the problem. There won't be times when it's better than worse, because it's at the level of speech production, not in planning. And so the planning is fine, but the muscles aren't capable of doing those movements, either because the muscles themselves are affected or the nerves coming to them are affected. And so that again is dysarthria. And so people with dysarthria will have trouble with all tasks involving these areas, whereas people with apraxia of speech will probably only have trouble with speech. There are other kinds of apraxias where you could have trouble with swallowing or other types of tasks, but in terms of speech, apraxia of speech is separate from other tasks involving the mouth and oral structures. So that's sort of the general differentiation between aphasia, which is purely a language problem, apraxia of speech, which is a motor programming problem, and dysarthria, which is a problem of muscular innervation. And then one thing I guess I should also say is I'm talking about each of these as distinct disorders, but people can have a combination of them, and they can also, based on where they had damage, have different accompanying problems. Like we said, someone could have a right arm weakness with aphasia, or they could have cognitive problems, trouble with memory or attention, but that is not the aphasia. That's separate from the aphasia and in addition to the aphasia. So very often people think because the way humans interact to express their thoughts is through language, that people with aphasia, because they can't express what they want to say, aren't having the right thoughts. That's not true. People with aphasia are having the thoughts and do know what they want to say. They just can't get the message to where it wants to go. But, you know, if you measure people's intelligence in nonverbal ways, people without additional cognitive disorders will test within normal cognitive skills if you're not testing them verbally. So I guess those are some of the important distinctions among the different related disorders and what aphasia is not. And so what I'm going to present today are 10 ways that people with aphasia can help themselves at home. And because a lot of the people that reach out for help tend to be people with expressive aphasia, a lot of these are centered more towards people with expressive aphasia. However, a lot of these do carry over to any type of aphasia, but people who don't understand need to work on that first before they can work typically on expressing more complex thoughts. They should still be able to express things that come independently from them, people who don't understand other people, but they'll have trouble responding to incoming language. So these tips are primarily aimed at people who are understanding enough to then take the information and apply it to their language in response to other incoming language. But this one applies to everyone. So the first one is, in order to get better at language, you need to practice using language. So you need to talk. Now, this can be very hard for people at home with aphasia. Many times people with aphasia, unfortunately, their social circles tend to decrease after a time. And I think a lot of friends and sometimes even family don't know exactly how to communicate with someone with aphasia, because people in general have probably not heard of aphasia, don't know how to interact with people who are having trouble communicating, and kind of back off because I think they feel a little bit like they don't know what to do. And so unfortunately, their discomfort winds up further isolating people with aphasia, even though they're already somewhat isolated because of the lack of ability to communicate. So it's an unfortunate spiral, but I see it a lot. So even if you're on your own at home by yourself, I like to tell people that they should just be talking anyway. If you have an animal at home, definitely talk to your animal because that happens to have been studied, and it's shown that people are less stressed when speaking to their animal than generally speaking to other humans. And so it's a good practice partner because they're not going to judge you and they're going to be very happy to have you, spending time with them in whatever form you're doing that. So the different activities you might want to try if you're home alone and talking either to yourself or to other people or to animals or whatever you're doing. Some activities that you might want to try are at whatever level that you can, whether it's single word or 2-word phrases. Always try to aim for the next higher level. Not too challenging, but not under challenging either, right? So don't keep doing the same thing for a year. You got to keep stepping it up, right? Or you're not going to improve. But in any case, just pick like the next highest level. If you're saying 1 word, try to add another word. But try to think of descriptions for the things you're seeing, naming the objects in your environment. You can try to relay the plot of a TV show or movie to somebody, list ingredients or the actions that you use in recipes, talk about things that you're currently doing using verbs. A lot of times, for some reason, people tend to focus mostly on nouns and naming things and not really talking about actions as much. But in order to have a full sentence, you need both. So that's something that I like to focus with people on is verbs sometimes, because generally if you have a verb, then you need a subject and an object. So you're going to get a verb and then 2 nouns. So it's a good way to start to expand utterances if you're working on increasing utterance length. And talking about things you're interested in is always a good idea. So hobbies, people, activities, things you're planning on doing, places you've been, talking about pictures you have in your house, things like that are helpful. So that's the first one, is talk, practice, practice, practice all the time. And if you have someone to talk to, even better. I mean, that's obviously better because you can get more interaction, more feedback, help if you need it. If you're working with someone with aphasia who you're helping, and you're sometimes not sure where they're headed, one of the things I like to suggest is sharing context. So stick to talking about a picture, or whether it's a photograph of people live, or whether you just take an image off of Google and talk about that. But if at least you know the basic context of what someone's trying to say, you'll be more likely to be successful in figuring out what they were attempting to say. So you have that shared context. It's better if you have someone who might say a tangent, or you might go in the wrong direction with guessing. Okay, so the next advice I have for people with aphasia is, this is on the person with aphasia, is if you're trying to say something, before you continue down a long road, check in periodically to make sure people are following you and understanding what you're saying. Because the further you go down a path, the more likely it is for miscommunications. Excuse me for a second. And so what I like to recommend is that the person with aphasia check in and make sure that they're following. So have your listener, restate what they think they heard, what they think they understood. Very often I'll initiate that. If I'm working with someone, I'll say, let me just stop you for a second. And I'll ask, like, is this what you meant? Or this is what I got. Is that what you meant? Things like that, just to check, because sometimes I've noticed, if somebody says a lot of things and I'm afraid to interrupt, then I might get lost very early in the beginning. And by the time they've changed a few words here and there, I have no idea where the conversation is going. Excuse me, my dog is starting to whine at me. A lot of you guys know my little Rosalina, but so I say, if you're conversing with someone with aphasia and you're not sure, it's better to say, like, hold on one second, I I think I got lost. Let's back off, something like that. So you can initiate it if you're working with someone, but it's also really good if the person with aphasia learns to check. And that's especially true with people who have apraxia or dysarthria, because sometimes people do not understand. And if they can repeat one single word, sometimes it really helps to make sure you're going in the right direction and that you're staying together on the same path. So make sure people are understanding you. And some ways to do that is directly to ask. Also monitor people's facial expressions, because a lot of times people will be like, they'll look confused all of a sudden, and then you can adjust and be like, do you understand? So that's very empowering for people with aphasia, is to realize they can control sort of the actions they're taking to make sure they're understood. And then if you've said something and you have aphasia and someone answers you and responds with the next sentence and it doesn't make sense with what you've said, just assume they didn't understand you and say, let me re-explain that, or something like that, a gesture. Instead of, if you can't say like, let me explain that again, just say, and then repeat. Because very often when you're having a conversation, like, it's obvious if the person didn't understand what you said. I used to have a lot of problems with my mother's boyfriend because he was very hard of hearing. And, every once in a while we'd have a moment where like something was completely misunderstood. And I'm like, did you say goat? And he's like, actually it would be him. He'd be like, did you say goat? I'm like, no, coat. He's like, oh, that made all the difference, So just, that's an example of like, if the person isn't getting what you're saying, they could answer something in a completely different way. And that's a really good clue for someone with aphasia to know that your message was not received properly. Okay, so then for people who are having trouble thinking of words and having trouble accessing their target word, sometimes you have to triage, right? How important a message is to you, especially because aphasia can be so frustrating for people, especially with expressive aphasia, when you really want to say something. And so instead of being frustrated all the time, sometimes it's worth deciding, that word might come to me in a few minutes, maybe this message can wait. Or other times, like, it's very important and you really want to make sure you stay on this message until it's properly received. And so in those cases, you should definitely choose to continue and to try all different ways of expressing yourself, which I'm going to cover in a minute, in order to get your message across. But other times, you should probably decide that it's not worth all the stress and pressure, because the more stress and pressure you have, usually the worse the language is going to be. So if it's very important, obviously you should continue, but if it can wait, sometimes it's better just to like triage and decide, okay, like, I'll get this out in a few minutes or another time or something like that. And if you feel like, your brain can't do it at that moment, sometimes a little rest is needed. So trying to like pick and choose when you're really going to battle for something is probably important to prioritize what you're expending your energy on. And then I kind of hinted at this one a little bit in saying, using all forms of communication, but there's many different ways to make yourself known. And it's important that people with aphasia are validated for getting their message across in any form, because, as we said, it's so frustrating not to be able to express yourself. And so if you're the person who's working with someone with aphasia and you understand their message, first of all, alleviate the stress and tell them, you understood, and show them this is what you said, regardless of how it was communicated. And then if you want to, you can help try to perfect the form of the message. But, it's equally valid if you get your message across. It's successful in my mind anyway, if you get it across by having to write or having to point to something or spelling it out or drawing. And there are techniques we call supported communication, where we make sure materials are available to someone with aphasia so that they can always access things to use as references. For example, you might want to have always, like, some of my clients will use like a whiteboard and, you know, an erasable marker or pen and paper. But you can also just have things available for them to use that are harder to reference, like things about time. So you could have a clock, you could have a calendar, you could have maps, you could have pictures of things they're likely to talk about. If there's certain interests, you know, you could have pictures, photographs, lists. If people are able to read, you can just have lists of common neighborhood people and places. Like if you're talking about running errands, you know, you might have things down like post office or returns or bank or whatever it is, you know, and people can just point. And then if you're inclined to want to help the person, you can give them cues about, like, you know, the sounds. Like if you know then that they want to say bank, you can say and help somebody to try to start getting the word out. But having different means of communicating is very helpful. And that being said, another thing, and this is a separate tip, is using technology. And then we have things that speech pathologists may recommend that are specific devices to help with speech. So we have things like where it's all picture-based or word-based, depending on whether someone can read or not. And that's something I probably should have said in the beginning, that language includes speech, which is expressive language, shorthand for it. For lay people, they say speech output, but expressive language, the receptive language we talked about, understanding, and then reading and writing as well. So people with aphasia may have trouble not only speaking, but also writing, but they may not. It depends on where the injury was and how it broke down for them. But if they can read, you know, it does make things a little easier. Same with writing, but there are still ways to get around it. And so back to technology, there's a lot of things, you know, that speech pathologists might recommend. So communication boards, and then devices that are similar to communication boards, where you're pointing to pictures or constructing sentences using individual words or just typing words even. But then informally, we can also just do all different things that are accessible to all of us online or with apps or different technologies. So, you know, someone might be able to email or use Facebook or use audiobooks if they can't read, but they understand things auditorily. You might be able to use things like we are today, like Zoom or other, you know, FaceTime, all that, texts, emails, text to speech apps where people can type in a word and then it might pronounce the word for them. And then there's plenty of apps designed specifically for aphasia and communication disorders. Two of the companies I like are Tactus Therapy, which is TACTUS, Tactus Therapy, and Constant Therapy have good aphasia apps, but they are ones you have to pay for. There are plenty of free ones too. They're a little more limited usually. Tactus and Constant Therapy I find to be more beneficial because they're designed by speech pathologists, and they're based on theoretical language principles. So they, at least to me, make a little bit more sense. But there's lots of picture naming apps and many different kinds of things. And then if anyone follows me on my Facebook group, sometimes I'll post different like pen and paper activities. And a lot of times I get them either from school websites or English as a second language websites. There are these days even some speech websites, but some of them aren't free. So I just like to type things in like fill in the blank sentences and just hit images and see what stuff comes up online. And so that's available for everyone. So another thing is having people in your life and the people you communicate in learn about aphasia and get support for themselves. Because a lot of people really just have no clue where to start in communicating with someone with aphasia. So, you know, even things like this, where you learn more about what aphasia is and about, you know, some things you can do to help people with aphasia is good. There are websites like the National Aphasia Association here in the United States. Heather, I don't know if there's a Canadian version of that, but there probably is. But you can always look at our American stuff, right? In any case, yeah, there's some good resources from the UK, like Connect, I think it's called, UK Connect, which is for people with aphasia. And there's, oh, I know one in Canada, actually. There's an aphasia center called the Pat Arato Aphasia Center, which is in Toronto. And it's Pat, it's a person's name, P-A-T, and then Arato, A-R-A-T-O. And they actually are the ones who started the whole technique of supported conversation, which I referred to briefly earlier, which is the idea of supporting people with aphasia to communicate in any way possible and giving them tools and resources in front of them at all times when they're communicating so that they can back up what they're trying to say with other means of communicating. And they've done a lot of research on this. So there's a lot of training for people who are working with people with aphasia on that website. So you can look it up either by looking at the Pat Arato Aphasia Center in Toronto, or you can look up supported conversation for aphasia, SCA. And there's a lot of research done about that and how to do it, actually. So that's another way for people to get information. But again, people who are trying to help people with aphasia, if you live with someone with aphasia, if your mother, father, son, daughter, husband, wife has aphasia, sometimes you need assistance too. And sometimes you need some therapy for all the feelings and changes that are going on in your life because the person with aphasia isn't able to communicate the same way they used to. And so sometimes, you know, people have a lot of feelings about changes in relationships due to communication. And so sometimes it's helpful to have somebody to talk to about things like that. And I often recommend that to family members. Okay, and so related to something else I discussed earlier, which is checking in with someone to make sure they're understanding you, is advocating for yourself during a conversation. So if you have aphasia and you know some things that help you, if you know, for example, it's better for someone to speak slowly, or it's better for you to have extra time, you can ask for it. And so, you know, you can tell someone to repeat themselves. You can say to say it again. You can say, give me a minute before somebody jumps in to help you. And these might be things that you develop a knowledge of for yourself over time. And so in the beginning, maybe you don't know exactly what helps you, but as you live with the aphasia, you see how someone jumps in too much and you're like, wait, I wanted to exercise my brain and try to do it myself. So ask for the time. Because sometimes you just need a little extra processing time. Sometimes people need the first sound of a word. Sometimes it helps if people give you a rhyming word for it. Sometimes it helps if you give something related to the word, like the category, or it's not an apple, but something like that, you know. Things like that helps people. So you can give meaning clues, you can give sound clues, but if you have aphasia and you know that one of those helps you, you can definitely ask someone, you know, especially if you've tried and you can't get the word out and you know what you want to say and the other person knows what you want to say, then that can be helpful. And so, like we said earlier, you can make sure your message was received. You can let people know you need a minute. You can ask people to slow down. You can speak slower, all those different things. So another tip, I think, is that people with aphasia, especially expressive aphasia, but even with comprehension problems, can often use very empty language. Like a lot of people with aphasia will say, you know, the thing, or that stuff, or, you know, the one, that one, you know, and you don't know sometimes. And so what's better and more useful is if you as a person with aphasia can give a little bit more clue, more hints in your word choices. And if you can't, and you're helping someone with aphasia, sometimes it's better if you ask questions like, are you talking about something we do or something we're gonna do, or like that. So you can help like clue in to what the person's trying to say. But once you know, it's really helpful not to give the person the word every time, but sometimes to ask them to give you more information. Like, what does it look like? Where do you see it? What does it remind you of? What category is it in? Things like that. And so if people give you more information, you're more likely to get a narrowed down context rather than having to figure everything out from scratch. So if people with aphasia could use a little bit more hints, then at least even if you can't get the exact word, you might point somebody in the right direction so that you're better understood, or so that people get the general gist of what you're trying to do or say. So I said like things like where do you, oh, my dog sneezed. I don't know if you heard that, but it wasn't me.
Bless you.
Thank you. Thank you. So you can tell people, like I said, things it looks like, what it's made of, what it reminds you of, what it's associated with, where it's used, what you use it for, its function. Anything like that might help somebody. And it also can help you with aphasia to get the word out, because sometimes it's a matter of strengthening networks in the brain. And the more information you can access, sometimes it will help the word be raised to threshold and be able to be produced on its own. So even if you can't get the word out by saying it, you're giving other people a clue. And sometimes it also helps to stimulate the word to be produced on your own. And then finally, this is something newer to think about, but because, as I said, the neighboring brain areas where aphasia might originate, okay, let me say that again. Let me do that differently. So if you have, for example, damage in your brain in Broca's area, so anterior, posterior frontal region, like around here, and right arm function is right next door, then sometimes people thought that areas around that survived the stroke would be competing to use those surrounding areas for neuroplasticity and to take up language function or arm function, and that both probably couldn't be supported there. But newer research suggests that using your right hand can actually stimulate language production. So that was one of the things I was looking at in my dissertation. And so actually it looks like both can be supported by the areas surrounding the damaged area, and that by using your right hand more and stimulating your right hand if it's weak or paralyzed, you might be stimulating areas that are also going to be the areas that can take up language function. And so by using your right hand and not letting it, just sit idly there or limp by your side, and trying to use it, trying to initiate movement in it, even if it doesn't result in motion. But by using that part of the brain to try to use the arm, it can also help those areas that can be primed for language recovery to be stimulated. And so I suggest using your right hand. It's good anyway because you want to be using that hand, but it does seem anyway with the newer research to be useful in stimulating those areas rather than competitive. So people used to say like you either had to pick to do PT or speech. You could only concentrate on one for a certain long period of a certain short-term intensive period of time. But that seems to not be true. That was just a guess. And I think, more empirical research is coming out suggesting that that may not be true. And so I suggest using your right hand. And those are my 10 things. So at this point, I can toss it back to you, Ralph.
Okay. I'm going to switch back to gallery view. One of the things that we like to sometimes do, we open it up for questions, but one of the things that we sometimes like to do is we have some new folks today. And so we thought we'd go around and just ask people to introduce themselves, tell us very briefly about their stroke and any challenges that they're dealing with. I don't know if anybody out there has language issues, so you'll see me leaning in to read the little teeny tiny letters. And if I call on you and you don't want to speak or you have language issues, just shake your head and I'll move on to the next person. This isn't about embarrassing anybody. So Heather, tell us a little bit about yourself, if you would.
I had my stroke 2 years ago. I have stroke. I have formed, what you call it?
Or an accent syndrome.
Yes. So I speak with a French accent and spell with French accent, but I'm not French.
Remind me to, Carolyn, to tell you, to talk about this, is I have a friend who speaks in a German accent. He was German, but he had been in the United States for 25 years and completely lost his German accent. Always made me wonder if he was like, somehow his brain reconnected with the 6-year-old Marcus instead of the 60-year-old Marcus. Anyway, thank you, Heather. We know Dr. Hetzler talked about his stroke last week, and Winnie comes every week. So Lisa, tell us a little bit about yourself, if you would. Lisa Brown.
Hi, my name is Lisa Brown. I had the stroke 6 years ago. It's really still hard to speak, but I'm getting better and better. So
Sound
You're
great?
doing very well, I think. I don't know what Carolyn thinks, but just my limited experience, you're
Yes.
getting on the more towards the back to normal side of things rather than the struggling to put two words together things. Good job. Keep it up. And Sandra, how about you? Let me make sure you're muted. There you go.
Yes. Sandra Rolfe. I have my stroke 5 years ago and 6 months ago. 5 years ago and 6 months ago. Yes. Yeah. I have my aphasia and right arm and right leg, some paralysis. Yes.
Good job. Keep it up. You sound like you're doing pretty well too. I had no idea I was going to call on 3 people in a row with aphasia, but here we go. So Taylor, tell us a little bit about you. And welcome, by the way, welcome to Heather, Lisa, Sandra, Taylor, John. I think we know John, Sherry. I think might have seen Sherry, Debbie. I don't know. Joe, we do, Sammy, and Denise. So welcome everybody. Appreciate you coming. Back to you, Taylor. Are you
Can you hear me?
Yeah.
Okay. I'm actually Lisa's daughter. So I just came on to sort of be involved. We're working with Carolyn, so I found this yesterday. So I'm just here to be a part of it.
Well, I'm glad you're here, and I think that's important. And if you read the promotional copy, I made a point of pointing out that this should be for caregivers because, you know, I have some friends who made a movie about a guy who had aphasia, who had a stroke. A friend of mine actually, and they're friends of mine who made the movie. It's called Aphasia, the movie. Hope is a 4-letter word. And Carolyn, I need to get you information on that. You'd be very interested in it. In fact, they've just opened it up for viewing. I went to the premiere 9 years ago because Carl McIntyre was a friend of mine, and they've just opened it up for viewing. And I thought about playing the movie here in this meeting one week.
I've seen that movie many, many times, and I've played it in class.
Oh, really? And Carl McIntyre, I had a video company in Charlotte, and Carl McIntyre had hired him for a number of bank training videos and stuff. What worse occupation can you think of than somebody who's a leading actor in a city to get struck down with aphasia? You know, if you operate a backhoe, you know, you don't talk to a lot of people. Yeah. But if you're an actor, you can make your living delivering lines. So, yeah. Taylor, welcome, and I'm glad you're here. And, you know, part of this whole thing to me was a caregiver thing, because as Carolyn knows, I remembered the point of bringing up aphasia. There's a great line in there, and it says, what happens to one happens to two. And that's particularly true with aphasia because you really, if you have aphasia, you really need a partner to help you. Or if you have a partner, then it's beneficial to have a partner. So
Right.
let's see who else we got. Sherry, I'm not sure if you've been before. Kind of hard with that mask on.
I'm Sherry. I had a stroke 2 years and 8 months ago. I have aphasia, and I liked her talking about the use of the hand helping the neurological parts too. I didn't realize that.
Yeah, that's newer information for sure.
Yeah, because over this last year, I focused on using my hand. I wash dishes mostly, and I get better at washing dishes. So, and when I hear this, I was like, okay, that makes sense more.
Yeah. Oh, I'm glad that was useful for you. So that's definitely new information.
Well, one of the focuses I've been taking lately, particularly with these Tuesday meetings, is I hesitate to put it just under the term neuroplasticity, but what we need to do as stroke survivors, in my opinion, is understand the things that we're dealing with and learn about them scientifically and learn about the things that we can do that are effective. Because so many people it seems to me, put in a lot of time. They've got a good attitude and everything, but if you, it's, the more focused your approach is and the more scientific it is, the more beneficial that time is likely to be. So that's kind of been my focus with these things is, trying to bring some information that is new, scientific, neurological, relates to the neurological aspect, and give everybody practical takeaways, which I think Carolyn did an excellent job of. I knew that because she and I had talked and we went over them. But anyway, we've got Debbie. I don't know if Debbie's willing to talk or not. I think that's about, and Denise, they're the only two. So Debbie, are you there? Maybe not. Okay, she can't shake her head, so she didn't say anything. I'm going to move on. And one more is Denise. Okay, Denise. So there you go, Dennis. We went around, and Dennis likes to everybody introduce themselves. So I want to open up for questions briefly. I've got one, Carolyn, and that is, we all know that it's very frustrating. I've worked with a couple of people who have aphasia. Well, one who has it pretty seriously. So what do you do when you're trying to interact with somebody to try and reduce that frustration? It seems like it's an endless game of charades, for lack of a better term. And so should you play charades, and what are some tips to cut through the frustration level? Because sometimes when I'm interacting, well, it was with one guy I took towards, instead of playing charades, I brought him a yellow pad and had him write down like a keyword. And then I could often understand what he was talking about. He's one who says the thing for just about every noun out there.
Yeah, that's pretty common. So I think if I was starting with someone, so often the more you know someone, the better able you are to start figuring out and narrowing down what they're trying to talk about. But if you're just meeting someone and you don't have a lot of common knowledge with them and shared information about what they might be likely to be talking about, as I suggested during the list, is to try to narrow and constrain the potential topics by having some kind of reference that you're both talking about together. And so I usually start, when I'm just meeting somebody, with things that we can both look at and know what we're talking about, because it's much easier for me to redirect somebody if I have a general concept of what they're trying to talk about, than if it could be anything in the whole wide universe. But if you find yourself in that situation, I think, you don't have that much choice but to ask a lot of questions, or, as you said, ask for them to give you some more input. If someone's able to write, that's often an amazing extra piece of information you can get, but a lot of people with aphasia cannot write. And so that doesn't help them. And people with more severe aphasia may be very limited in what they're able to say. There are some people who can only say one word and things like that. So in those situations, I think, what you really have to do until you get to know somebody. I'm sorry, my dog is whining so much. I don't know if you're hearing her, but she's really whining. Sorry. I really feel like I have to narrow down the topic of communication so that I have some possibility of figuring it out. Because if somebody's working with me for an hour, I don't want to spend a half hour, 40 minutes trying to get one message. One of the most important things we need to do is get a lot of practice talking inside each hour, because the amount of practice matters, especially in a certain amount of time. So you're always trying to do as much and as many repetitions and things as possible. So as I also said, sometimes I have to ask people how important that is, because I try to explain to them, we need to use our time wisely, because if you're paying for an hour of time, you really don't want to get stuck in one communication for, the whole time. And it can take that long sometimes to really narrow down what somebody's trying to say. If it could have been anything, you really have no idea. And so, unless it's super important, and sometimes it is, and sometimes because I'm the only one who will sit there for an hour and try to figure it out, I wind up being the person who will take that long to figure out one message, but it's not optimal for therapy. And so I try not to do that. But if the person hasn't had a communication partner that has the time or the knowledge of how to try to get information from someone, I may do that. But I try to persuade people that it's not the best use of their time in therapy.
Well, in this case, it was, it wasn't a session. Well, it is a session. I'm doing physical therapy with them, so I kind of know that. I was thinking at first, well, I can't do that. I can't come prepared. But we actually, I know the context, because the question is going to be about like what I'm trying to get him to do, what I'm instructing him to do. He's got some feedback about why maybe he can't do it, or why it's difficult, or something. So that does help. I just feel so bad when I'm around folks with aphasia, because I feel like I'm contributing to their frustration, and I would like to have more skills so that I could interact with them in a way that was less frustrating for them. I just can't imagine what it would be like not to talk. Can you imagine, Dennis, if I couldn't talk? Oh my goodness.
No, but being from New York, I love the idea that I could use my hands.
Yeah.
Are you Italian too?
No,
Yeah.
I'm Irish, but
Oh, you're Irish. Oh, Falvey. Well, I mean, what am I thinking? Forget about it. You're not Italian.
but I love to use my hands.
Carolyn's from New York. She lives in Babylon, Long Island, I believe.
Right.
Yeah,
That's-
Carolyn knows where I'm coming from.
I'm a original New Yorker. I'm a mutt, but I guess I'm mostly English, Irish, Scotch, and Scandinavian, because everybody who's from the British Isles has some Viking in them. And yeah,
Could I comment on something, Ralph?
Pardon?
Could I comment on something? I don't know how much time we have.
Yeah, we have all the time in the world. We value your input.
Well, okay. Well, there were two things I was going to mention. I'll mention one first, because probably people haven't heard of this. And this is the possible importance of listening to vocal music if you've got Broca's aphasia, that is expressive aphasia. And this is based on a study just published in the July-August issue of the journal eNeuro. It was a study done in Finland and involved stroke survivors in the subacute phase, that is 3 to 11 weeks after the stroke. They were divided randomly into 3 groups. One group received or listened to vocal music, people singing the music of their choice. So it was a genre that they liked. Second group just heard instrumental music, again in the genre they liked. And the third group listened to people talking. It was audiobooks. And they listened for 1 hour a day for 2 months after the stroke. And they found a month later, they did a test of all 3 groups, and the group that listened to the singing were significantly better at speech production than the other 2 groups. And a diffusion tensor imaging, basically a type of MRI, showed in the left frontal lobe that there were enhanced connections, axon pathways, in the group that listened to the singing. So now that was right after the stroke. I have no idea if that would be effective later on. like 5 years later, but it seems simple to do. You listen for an hour a day to people singing the sort of music you like, country western or whatever. So that was one thing I wanted to mention. Then I wanted to ask Dr. Falconer how effective constraint-induced speech therapy is. This is a variation on Edward Taub's constraint-induced movement therapy.
Mhm.
In
Yeah.
constraint-induced movement therapy, if your left hand's affected, you wear an oven mitt on your right hand for a month or two or whatever. In constraint-induced speech therapy, basically the patient is not allowed to gesture or use a keyboard. They're basically forced to talk. Any comments on that?
Yeah, I have a ton. That's actually funny because constraint-induced aphasia therapy was actually what sent me back to school for my PhD. And I had many conversations with Dr. Taub about this because at the time when I went back to school, there were only a couple of studies and they were called constraint-induced language therapy by Lynn Mayer. And she was comparing multimodal therapy, which a specific type called PACE therapy, where you can use any form of communication with the same intensity and dosage as the aphasia therapy that you refer to, where people had to speak. And what was found in her studies was that whichever thing you focused on primarily during her couple of weeks of intensive therapy were the things you improved on. So if you tended to draw pictures or tended to write words, you got better at that. But if you tended to speak in language, you got better in that. So it pretty much showed that it matters what modality you practice in. And I'm a big proponent of intensive therapy in general. And that's one of the things that hasn't been super separated out in constraint-induced therapies is the intensity of practice and the mass practice schedule and the shaping. So one of the things I had discussed with Dr. Taub was about my thought that a lot of the early users of constraint-induced aphasia therapy were trying to make everything be blocked so that you couldn't see the gestures somebody was doing. People thought it was going to be a lot like the oven mitts that you described, where they're physically constrained from using gestures or any other type of output other than language. But what we were discussing was the fact that what it had to be was not that you didn't use those things, but that couldn't be the communicative aspect of it. So if gesturing or writing or any of those other things helped you to come out with the words, that was okay. Bye, Heather. Thank you for coming in. That those would probably be permissible even in his form of therapy, because the important point in that was that you had to produce the word ultimately. And so even if that meant by shaping that it had to be a repetition, that was okay. But what a person couldn't do is just get by with writing or gesture or any of those forms of communication. They ultimately then had to say the word, and for other people, at different levels, they had to say whatever was prescribed for them, the number of words or putting formal requesting behaviors in and things like that. So people are still trying to figure out what the active ingredient is in that therapy. But it looks like it's speaking. So it seems like you have to speak to get better at speaking. And I think that makes sense to anyone who studies learning, because you don't get better at something that you're not practicing. So basically, that's the overall finding. And in terms of music, I mean, that's long been studied in aphasia. The passive, more listening aspect of it and then measuring output is probably newer. But I get, like you said, having somebody improve by doing that at a chronic stage might be different than somebody in the subacute stage, because you know, they have so much active reorganization going on and spontaneous recovery happening during that subacute period anyway. Many aphasia studies don't include subacute patients for that reason. We want people to have stable disorders, so we know the intervention we're doing is the cause for improvement. But, you know, they had 2 good control conditions in there, so that should probably, I don't know, although many aphasia studies have very few participants overall, so I don't know how big each N was in each of those conditions, so I'm not sure. But it is interesting, and why not listen to music if you enjoy it and you're recovering anyway, right? It's not going to hurt. So I think that's a great bonus piece of information, and I'm glad you shared that because I had not heard of that finished study.
Thank you.
Lauren, I assume this is music to your ears, literally. You don't have to comment. You can if you want. Somebody asked me to ask, and maybe this is a question of both Carolyn, both Dr. Falconer and Dr. Hetzler, and that was about masked practice in terms of speech therapy. I heard you mention it briefly, Carolyn, in your last explanation, and Dr. Hetzler, you're welcome to chime in. I assume if the brain learns by big blocks of repetition, that's going to carry over from, you know, physical things to other activities that the brain tries to engage in. So I'll shut up and let the experts talk about this.
Well, no, I mean, I think what Dr. Hetzler said is very important, is that a lot of therapies that we're using now in aphasia, not the ones born from linguistic theories or from cognitive psychological models, but the ones born from other rehab professions, are often based on principles discovered by neuroscientists working in general with neuroplasticity, or by, you know, physical therapists and neuroscientists working with motor learning and things like that, and then trying to take those concepts and apply them to language. And some are more directly applicable than others. So mass practice is certainly one that covers, that probably crosses many cognitive modalities, I would guess, because learning is learning, in my opinion. And yeah, I think I touched on the mass practice when I was answering about constraint-induced aphasia therapy, but also in one of the questions you asked me earlier about, you know, somebody who's staying on one subject for a long period of time, maybe due to frustration and really wanting to get a point across. And I said, sometimes I don't want to use a whole session doing that. If I need to, I will, obviously, but I don't think it's optimal for generalization and language relearning, because it's only really learning to get that one point out. And it's not applicable to techniques that would get every point out every time you wanted to speak, which is what I'd rather invest time that people are paying me for in. So that, you know, anytime they want to get a word out, they're learning techniques for how to get any word out, not just for that specific word, that specific time. And so practice, 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 in my opinion. But I'm curious what Dr. Hetzler thinks.
Well, I think you said it very well.
Thank you.
There's very little I would probably add to that, because speech is a motor output, just like moving your hand or your arm or your leg is a motor output. So I would assume that mass practice, talking or trying to talk, would be far more effective than distributed practice.
Yeah.
And interestingly enough, it depends on your perspective too, because see, your perspective is helping people in sessions, Dr. Falconer, and mine is, I was thinking like, you know, I'm always thinking like, what are they going to do at home? So, you know, I meant like, you know, in terms of like practicing. So I would assume if you are going to practice something, that engaging mass practice as much as possible would be beneficial. And I'd like to add that I know a couple of people. One had a TBI instead of a stroke, but she presented very, very similar in both physically and mentally in speech. Another was a stroke survivor, and they both got better with expressive aphasia. Just make sure I'm learning this right. they got their very first language going by listening to favorite rock and roll songs because they knew all the words. And at some point, one friend is local here, and I helped her locally in person as well because I could. And she literally, her sister, bless her heart, recorded a lot of her. Like, she'd be riding in the car and she would play Frankie her favorite songs, and then suddenly, all of a sudden, Frankie was trying to mouth just a couple of the words, and then she got a couple of them out, and then she was singing the choruses, and now she can put a few words together. Is she where she wants to be? No, but that was the breakthrough thing for her, so I thought that was interesting. Not being a doctor, I have to do everything based on my observational skills.
So I do want to make a distinction between music and language in those points, because pre-learned songs are usually stored in the right hemisphere, which is usually not the area damaged by a stroke or a brain injury that would cause aphasia. And so often right hemisphere language is still able to be produced, which can be very encouraging for somebody with aphasia, but is not to be confused with novel language. So on the right hemisphere, we store many types of automatic speech, which is including things like pre-learned lyrics, prayers, anything like long and automatic that you can just say. For example, when I worked with a priest once, he could not speak really any productive novel words, even like a single word at a time, but he could rail out an Our Father or a Hail Mary or anything like just fluently, because it was so overlearned and probably stored in the right hemisphere and basal ganglia at that point. And so not left hemisphere mediated. And so people many times try to use language learning activities from right hemisphere based pre-learned stuff, and it's not quite the same. There's also many other speech formula and formulaic languages stored on the right side. So things like, hi, how are you? And hey, how you doing? Things like that might just pop out from somebody with aphasia because they're very common, like social phrases, thank you, see you later, stuff like that. Any kind of proverbs that you often say, curses, those are all right hemisphere things, and people with aphasia can whip out curses a lot of times and they can't say a lot of other things. So that's because those are probably stored in intact brain areas.
Very interesting, because I actually, another example I observed was a minister, and he said, well, he didn't say, but Dr. Robin, the psychologist running who was in the rehab hospital I was in, I used to go back on Tuesdays and Thursdays and walk in as a stroke survivor to try and give other people in there hope, because I remember what it was like sitting in there in a wheelchair, not being able to stand up. And anyhow, there was a minister in there, and he couldn't say a single word. And Robin had said he never used to sing, but apparently he knew and stored all the hymns, because, well, I don't know why he didn't sing, because he sang for us, and he had a beautiful voice, and it was like perfect in every way, perfect pitch, a cappella, no trouble whatsoever with the words. So it's interesting that it's a opposite side, because I actually, I kind of like watch the other person, Frankie, on these videos every couple of days. It seemed like that had something to do with the breakthrough. Me being a guy interested in patterning and other opposite sides, both bilateral and ipsilateral patterning, and one side helping the other. I guess I made some assumptions, although maybe as we're talking about it, I'm thinking maybe there's actually something there, even though it's stored. I don't pretend to know.
Yeah, there is something to it. think, especially because with the corpus callosum, everything's so cross-wired, but language is one of those things where it's not bilateral. Most people's language innervation is on the left, and maybe 15 to 20% of people will have language instantiated developmentally on the right or bilaterally, but most people have it on the left. And most other functions are pretty well instantiated bilaterally. Like arm movement is very symmetrical bilaterally, and leg movement and things like that. But language is not. It's very much a left hemisphere function for most people. And the right hemisphere has some roles in language, as I was saying, but they are usually in harder to detect language functions like understanding emotion or pragmatics, or pragmatics is using language appropriately for the environmental context and the people you're speaking to. And things with prosodic contours. So like the melodic intonation line of speech, which we use to show different emotions or put stress, or it can even change meaning. Like if I say to you, if I use the same words, like I kicked the soccer ball through the window, right? And if I say I kicked the soccer ball through the window, I'm using stress and volume on the I to differentiate between saying I'm the one that did it, not you. Like I'm not blaming somebody else. I'm taking responsibility for that. And it's me. Whereas if I use the same words and I say I kicked the soccer ball through the window, then I'm not saying I threw it. Like using the prosodic, melodic intonation cues for people to hear that work in English anyway, of stress and loudness in order to emphasize the word kicked. And so I'm differentiating from another activity that could have sent the ball through the window. So those are right hemisphere mediated functions. So there are different uses of the right hemisphere. And a lot of people used to presume that the right hemisphere would take over language function in those who had language damage from a left hemisphere injury. And using different brain imaging studies, that has been found to be the case in the beginning of recovery, but better recoveries are predicted for people whose laterality returns to the left side. So people initially, because the pathways across the corpus callosum are usually untethered, so to speak, when someone has a left hemisphere stroke. And so the right hemisphere starts to try, it doesn't get, I don't know what word, I want to say disinhibited, but that's not what I want to use because it's complicated. So the right hemisphere does try to become more active, let's say, and try to do more of the language production, but it's not really good at it. It's not made for it. The left side is, for some reason, we don't know why, in most people, 80–85% of people. And so what we found is over time, if you look at people's recovery courses periodically and take MRI images, functional MRI basically, what happens is that people's early laterality change to the right. Then for people who successfully recover, switches back to perilesional areas surrounding the lesion, which is why I was saying to use that right hand, because it stimulates those perilesional areas. And so people whose language gets sent back over to the left have more successful long-term recoveries than people whose right hemispheres try to do that. So I try to encourage left hemisphere activities for language. A lot of people try to use music and stimulate the right hemisphere. And I say go ahead and do that, but when you're working on language, you should work on left hemisphere activities and try to stimulate left hemisphere use, in my opinion.
Well, and I know another reason I like doing this is I learn stuff every week, and Dr. Hetzler may have something that he wants to add here, but he's also agreed to, at some future date, we haven't picked a hard date for it yet, agreed to do a presentation he has on the language centers of the brain on both sides. And so I'm looking forward to that. so that I can learn more about this, because one of the things that you said earlier, Carolyn, was learn all you can about aphasia. Well, you've got the aphasia soapbox. I get up on the whole stroke soapbox. Learn all you can about stroke, learn all you can about the brain, learn all you can about neuroplasticity, because it'll serve you well. And Dr. Hetzler, if you have anything to say, you're welcome to. I don't want to put you on the spot, however.
Well, I just found everything quite interesting. And I was wondering, Dr. Falconer, have you dealt with cases of conduction aphasia?
Many.
Relatively, many.
Yeah. Is that what you have?
No, I don't have any problems with aphasia.
Oh, okay. I, for some reason, was wondering if that's why you were asking.
No.
Yes, so conduction aphasia tends to affect the, as you probably know, but I'll explain to everybody else, the white matter pathways between the two areas I spoke of. So between Broca's aphasia and Wernicke's aphasia, or Broca's area and Wernicke's area, sorry, there's tracks that connect the two. And so those tracks are basically used for repetition generally, because what happens is when something comes in, one of the ways you can test conduction aphasia easily is by trying this. So with conduction aphasia, those pathways are disturbed. And so the conduction from Wernicke's area to Broca's area is disturbed. And so one of the easy ways to test whether somebody might have conduction aphasia is whether repetition is more severely impaired than would be expected from other language tasks. And so the reason repetition is such a good test for this is because of the relationship between the two areas. So with repetition, what happens is I say a word like baseball, right? You hear it, you have to process it, and then you're sending it to Broca's area to be repeated, to be produced out loud. So you hear baseball, you process it in Wernicke's area, you use the white matter pathways to send that information to Broca's area, and then you can't do it. And so if you can't do it, and otherwise, you know, you're pretty much able to construct sentences and name things when you need to, you're showing that Broca's area is intact. And so by showing that Broca's area is intact, but the pathway going from hearing a word to saying a word is disrupted, you're showing that the conduction between the two areas is likely disturbed. And so repetition is very poor in individuals with conduction aphasia. And so therefore the errors that they tend to make in producing words are sound errors. And so sometimes it gets confused for apraxia of speech, but it's a different disorder and cause for different reasons. And so what happens is someone with conduction aphasia whose language understanding is working is their own personal feedback. They hear that they're making errors, and so they keep trying to correct it, but they can't because of the pathway being broken down. But once they know what word they're trying to say, they can produce it independent of the repetition cycle. So repetition is particularly bad, and errors tend to be sound substitutions or mistaken sound errors. Did you want to know something else about conduction aphasia?
No, and I think that comes in. I just wondering how many cases you had of that. Broca's and Wernicke's.
Broca's is usually my most common aphasia that I see. Global aphasia is, I see unfortunately a lot too, which is a very severe aphasia. That's when understanding and expression is affected. And so people with global aphasia have a very hard time communicating. And then after that, I would say I see Wernicke's most often, and then a combination of the other ones like the transcorticals and anomic and conduction. But people with anomic and conduction aphasia are more mild generally. They're fluent. They usually do well in most circumstances. But like I said, with conduction aphasia, they have a lot more trouble with repetition. So in the chronic stages, you're less likely to see them because they're probably very functional.
When I taught a bit about language disorders when I taught at Lawrence University. I'm now retired. But the example I would always give for Broca's aphasia was Jan of Jan and Dean. Jan and Dean were a rock group who were early contemporaries of the Beach Boys.
Okay.
And probably the two biggest hits were Little Old Lady from Pasadena and Dead Man's Curve. Won't come back from, anyway. The point of that was that Jan was in an automobile accident that damaged his left frontal lobe, and he was paralyzed on the right side of his body and had Broca's aphasia. Very telegraphic speech, could hardly say anything, but he could still sing fluently, because singing is generally a right hemisphere function. And I use that as my example of
That's right.
Broca's aphasia.
We use YouTube a lot now.
That makes sense.
We show people who've put their YouTube videos out there. I tend to use Sarah Scott a lot because she's a young person with aphasia who over the course of 7 or 8 years, she's improved dramatically. And so I like to show my class, you know, the progression and how aphasias can transform into other types of aphasia over time. So like somebody with global aphasia might evolve into Broca's and then into anomic, and might live at the anomic stage for a long time. You know, things like that. So I like to show how people recover. And I'm always trying to remind everybody how much people with aphasia can recover, because I think there's a horrible myth out there that after 6 months or a year, people aren't going to improve anymore. And that's not the case, especially with good intervention. I often like to make sure my students know that people can improve. So a lot of people who work with people with strokes, like doctors who see them at initial stages in the hospital, may not even realize that people improve so much because they don't see them returning back to the hospital to show their recovery. And so I think a lot of false information gets passed out sometimes. And so I want to make sure my students know.
Yeah, I know personally, well, you didn't hear my story, but anyway, I had a severe hemorrhagic stroke and a neurosurgeon had to drill a hole in my head, put a tube in.
You're lucky you're alive.
Well, yeah, the attending neurologist that night told my wife I probably would not be alive the next morning. And I don't know exactly how long after that, but I was released from the hospital 2 or 3 months later in a wheelchair. And I went to see the neurologist, and I don't know the exact time, my wife would know. But I moved to a walker and I went in to see her and she got tears in her eyes.
Oh.
She didn't think I would live through the night even. So.
Yeah, hemorrhagic strokes are very scary.
Tell me about it.
Tell me about it. Yeah, the statistics are about 15% of people with ischemic strokes die that day. With a hemorrhagic, it's 40%, and another 10% die within the week. So it's 50 versus 15, roughly. I've always looked at a hemorrhagic stroke as a type of aneurysm that doesn't kill you. I mean, I know there's technical.
Ruptured aneurysms are hemorrhagic strokes. So.
Yeah, you know, I mean, I understand there are technical difficulties. One quick thing, and this is something that I've noticed, and this might help you with, not you, not the doctors, but people who are dealing with somebody who has aphasia, like say Taylor, and that is that I've noticed a lot of times, something you said, Dr. Falconer, cued me onto this, and that is I've noticed a lot of times when they get close to the word, I don't know if it's expressive or the communication between the two areas, but they'll often say a word that rhymes with the word they mean to say. So I learned that by observation at some point, and so I factored that into my bag of tricks. You know, when they're saying something and you're running all these things, okay, we're talking about this, could it relate to that? One of the other things that I've done is, could it rhyme with anything that's talking that we're talking about? Because that I found that to be a bit of a clue.
Yeah, a lot of times people will get the first letter right too, and then they might say a different word that starts with that letter. That's
yeah, that too. I've noticed that too. But what I've noticed more was like the front letters are different, like pounce and once. That's not a good example, but it's the first one that popped in my head. Something
No, I
the
understand.
beginning is off, but the end seems to rhyme. Anyway, you could add folks out there trying to help their loved one could use both those tricks, rhyming and getting the first part right and then going astray, which is what you just added. So, gosh, we've taken up an awful lot of your time, Dr. Falconer, and we certainly appreciate it.
Happy to be here.
If anybody's got any more questions or input or anything they want to add, this would be the time before I close it out.
Let me just say, this is Dennis. Thank you very much, Doctor. I really appreciate it. You know, I personally don't have it, but I like what you said about training available for the caregivers. And Taylor, I commend you. I mean, I think I've always said this, the caregivers are the true warriors and the unforgotten often heroes, you know, because, you know, dealing with us is difficult. And so God bless the caregivers and thank you, Doctor.
Oh, thank you so much.
I see Lisa
Yes,
agreeing.
Taylor's
Sorry. I see Lisa agreeing strongly with your statement about the caregivers are the real heroes. So Taylor, take that to heart.
Lisa's a big hero too.
Thank you. I appreciate that.
All right. Well, this will go up on YouTube. Why am I saying that to people who are going to watch it on YouTube? Because if you're not here now, it doesn't matter. Anyway, we'll put this up on YouTube, and next week we have Dr. Hetzler is going to do a presentation on spasticity. And this whole discussion today, Dr. Falconer, for me, kind of upped the ante on the importance of his presentation on language areas. In case you don't know, Dr. Hetzler is a neuroscientist who had a stroke. And so I just find all this stuff fascinating because I'm just a guy who had a stroke who's spent the last 12 years trying to learn all I can. And no, I don't go to college over it. I don't dive into books till 2 o'clock in the morning. I just, in everything that comes my way, I try and learn about it. So I appreciate you, Dr. Falconer, as much as I appreciate Dr. Hetzler. And one of the things that I thought was just fantastic was today the discussion between you two. I mean, that's what, well, I mean, it's, you know, you have expertise across different disciplines and some commonality in subject matter. And I think that's what ought to be going on here in these meetings. That's the point of my having them. I learned, but you know, if we can really deliver, the whole point is to deliver useful takeaways. And I thought you, Dr. Falconer, you gave a number of really useful takeaways, and that's kind of my theme for this, as you and I discussed a few days ago, would be, you know, people come for information, so let's give them some. They don't come just to hear us, you know, run our mouths. So with that, I will stop running my mouth, and I will thank you again, and I will thank everybody for coming. And Dr. Hetzler, I just think it was outstanding that you showed up and contributed to this. And so
It was my pleasure. I really enjoyed it.
we'll
Thank
see
you, everyone.
everybody next week with Dr. Hetzler on spasticity.